Today I'm going to talk about another very important topic and the remaining part of acute gastrointestinal bleeding. Acute gastrointestinal bleeding is a very common presentation in emergency department. In the part 1, we talked about how to approach a patient with GI bleeding, how to differentiate upper GI bleed from a lower GI bleed, what things should be considered in a patient while managing a patient with GI bleed, what to look for, what are the treatment of choices in a patient with hemorrhagic shock that is due to excessive blood loss. In this lecture, we'll talk about some of the common problems that causes GI bleed, which includes structures involving upper GI bleed and lower GI bleed. So let's talk about a few of them. So differential diagnosis of upper GI bleed. Aortoenteric fistula. It ranges from rapid bleeding to mild to severe bleeding. At times, it's painless. It is most common in the patients with a history of abdominal aortic aneurysm repair. What are the signs? Look for shock. What are the signs of shock? Irritability, altered mental status, hypotension, tachycardic, increased respiratory rate, and decreased oxygen saturation or increased temperature. These are the signs of shock. And in these patients, look for signs of hemorrhagic shock, fluid depletion, and blood loss. What should be done in patients with shock? First line treatment, 2 liters of IV crystalline fluids, followed by blood transfusion. Replace blood with blood. Crystalloid solution can be temporary treatment, but blood loss could also always be replaced with blood. So signs can be of shock, as I mentioned, or normal with normal vital signs and normal GCS score. Workup: this patient needs urgent vascular surgery evaluation. So aortoenteric fistula is a patient who has a history of prior abdominal aortic aneurysm repair. This can present to you with mild and severe bleeding. The key point to ponder in this is the bleeding is painless. What you look for: shock or normal or no shock. What to do: urgent vascular surgery evaluation. Moving on to gastritis and esophagitis. Gastritis is most common presentation, especially in working in emergency department. It's the inflammation of gastric mucosa. What happens is it is associated with hematemesis or coffee ground emesis. Hematemesis is bleeding with vomitus. What happens is coffee ground emesis is sometimes called as black or clotted blood. Clotted blood at times is significant or indicates a heavier blood loss inside. So it can be associated with epigastric discomfort, signs of upper GI bleed, which includes hematemesis, as mentioned, or coffee ground emesis, melena, that's terry black color stool, or hematochezia. Hematochezia is more commonly in lower GI bleed, but at times can be associated with upper GI bleed. So melena and hematochezia, at times it is painless or no symptoms. What to look for? Again, emergency physician, you have to look for signs of shock. Hemorrhagic shock first. Rule out hemorrhagic shock. Is the patient maintaining airway, breathing, circulation, and the fluid resuscitation is adequate? Then look for nasogastric return. Put a nasogastric tube in. Aspirate what you can from the nasogastric tube. What it helps is to identify the bleeding. Is there any positive bleeding or not? Because at times the patient with GI bleed, when it reaches the emergency department, the bleeding is spontaneously stopped. But the patient gives you the history. So nasogastric aspirate would help you identify the presence of blood in the stomach or gastrointestinal tract. So what it does is it helps you make the diagnosis and help to clear the stomach or bloody feel, which is useful or used by endoscopists to identify the bleeding point. So early endoscopy within 24 hours is necessary in patients with gastritis and esophagitis. So moving on to Mallory-Weiss here. It is hematemesis with vomiting. That's hematemesis after vomiting. If a patient comes to you, the patient gives you a history that there's blood in my vomitus and after vomiting. Think of Mallory-Weiss tears. At times, it stops spontaneously. So at the time when a patient comes to emergency department, he might not be bleeding at that time. But he or she gives you the history of these kind of bleeding with after vomiting. Think of Mallory-Weiss tear. What to do? What's the signs? NG suction is important. What to do? Early endoscopy within 24 hours. Mallory-Weiss tears at times is related to alcoholics. Patients who are chronic alcoholic can present to you with these kind of symptoms, hematemesis after vomiting. Variceal bleed, esophageal or gastric bleed. Hematemesis, severe or mild. Melena, hematochezia. Nasogastric return. We are talking about some upper GI bleedings. Upper GI bleeding has similar symptoms in every disease that we study. It is related with hematemesis, melena, hematochezia, because these are the signs of upper GI bleed. Similarly, in variceal bleed, that's gastric or esophageal bleed, hematemesis, that can be severe or mild, melena or hematochezia can be present. What are the signs we could expect? Nasogastric return. Look for any bleeding on the aspiration of nasogastric contents. If there is any, urgent early endoscopy within next 24 hours. If not, for example, if there is the endocrinologist, the endoscopist, or gastroenterologist not available, you can insert a Sanger-Steken Burkimer tube, or Minnesota tube, or Linton tube. Sanger-Steken Burkimer tube is a tube-like nasogastric tube, but with two balloons inside. One is esophageal balloon, and one is gastric balloon. With gastric, when you inflate the gastric balloon, it does not allow the gastric content to go into reflux. With esophageal balloon expandation, it helps to put the pressure on the esophagus and give the compression on the bleeding vessels and stop them from bleeding. It has to be with a patent airway. It is said in literature, while you're putting a Sanger-Steken Burkimer tube, it is advised to maintain the airway with endotracheal tube intubation. Why is this so? Because Sanger-Steken Burkimer tube could rupture or make an esophageal tracheal fistula and can rupture esophagus. So protect the airway with endotracheal tube and then put Sanger-Steken Burkimer tube. Also, you can use Minnesota tube or Linton tubes. Linton tubes is one balloon straightforward tube. So these tubes are widely used in setups where the endoscopist or the gastroenterologist is not available. So these are easy to use and help to stop the bleeding. So moving on to duodenal ulcers. Hematemesis or coffee ground emesis. Patient comes to you with history of duodenal ulcer. At times, patients know that they have a history of ulcerative diseases inside. They can give you a history of pain that concern with the food. The pain started with empty stomach, that's gastric ulcer. The pain started with after taking food, that's duodenal ulcer. So hematemesis or coffee ground emesis with duodenal ulcer. Abdominal discomfort, melena or hematochezia. Again, the signs of upper GI bleed. there can be no symptoms. At times, there can be a plainness bleeding. So nasogastric tube can be positive, its aspiration can be positive in these patients or cannot be positive in these patients. Early endoscopy within 24 hours. Why is this so concerning that endoscopists should review these patients within 24 hours? Because at times, these patients with blood loss or suspected blood loss can deteriorate within no time. You have to be prepared and you have to be overprotective in these patients who are susceptible to GI bleed and hemorrhagic shock. So you have to maintain all the necessary life-saving maneuvers, things in these patients before delaying endoscopy and endoscopic treatment in these patients. Gastric ulcers, again, concern with the food intake, hematemesis or coffee ground emesis, epigastric discomfort, melena, hematochezia, or can present with no symptoms. Nasogastric secretion is most of the time positive in patients with gastric ulcer. Early endoscopy within 24 hours is highly recommended in these patients. At times, it is said in some literature with gastric ulcer, it is advised not to be over-aggressive with the nasogastric because it can perforate, it can cause damage to the stomach mucosa, which has already been damaged due to ulcers. So moving on to lower GI bleed. So lower GI bleed present to you with fresh blood, reddish blood. It can present to you with melena, but that's most of the time is due to upper GI bleed. Hematochezia is a sign of lower GI bleed. At times, most of the time, it can be a painless bleed. So some diseases that are common with lower GI bleed, that's anal fissure, that's erosions of the skin of the anal fissure canal. How to assess? Simple digital rectal examination. That's a painful examination in these patients. So painful bowel movements, blood with the toilet paper. What happens is the patient comes to you. At times, parectal bleeding is not being appreciated by most of the patients. They are not known about the melena or a simple branchial stool. So at a patient who are using toilet papers, they come to you that during the stool defecation, I had this blood-stained toilet paper. At times, they present to you with painless defecation. Patients with chronic constipation or hard impacted stool can present with bleeding due to erosions after the passage of the stool. So they can present you with painful bowel movements or blood with toilet paper. And on palpation, very tender. They won't allow you to examine. They won't allow you to put your digital rectal examination in these patients. So what to do in these patients? First and the foremost thing, pain relief. It's not always that with patients with anal fissure tend to lose much of the blood, but you have to be sure about it. This patient is within normal ranges of hemoglobin and blood levels inside. What else do you need? Urgent surgical consult for bleeding anal fissure and further management from the relevant specialties. So, angiodysplasia present with painless parectal bleeding. Painless parectal bleeding. Melena or bright red blood parectum. That's PRBPR. It's bright red blood parectum. Hemodynamically unstable. Angiodysplasia could be hemodynamically unstable. How do you identify the stability of the patient? GCS, blood pressure, mental status, temperature, heart rate, and oxygen saturation. These are very, very important. And what to do in the patient who are unstable? Treat hemorrhagic shock first. How to do that? Start off with crystalline fluids, moving on to blood transfusion. Blood transfusion, it should be rapidly and should be done within no time. But If uncrossed matched blood is available, go for O negative uncrossed matched blood. It can preserve the intravascular volume, can preserve the organs and prevent from end organ dysfunction. So early endoscopy, tag red cell study, and angiography. Endoscopy at times is very beneficial. Endoscopy is 75 to 90% diagnostic and therapeutic in patients with upper GI and lower GI bleed. Similarly with colonoscopy and sigmoidoscopy, but colonoscopy with lower GI bleed and upper GI endoscopy with upper GI bleed is very, very diagnostic and therapeutic in patients with bleed. But at times, the bleeding point could not be identified because of the stock of blood that's collected inside. So what to do in these patients? Angiography could be helpful in these patients. They can identify the minimal amount of blood that's been lost from the capillaries. That's 0.5 to 1 ml per hour. While the tagged red cell study can identify the blood loss from 0.1 ml per hour from the vessels. So these are very important, but endoscopy and colonoscopy are the highest and the definitive and therapeutic in patients with GI bleed. So moving on to carcinomas. Carcinomas in patient lower GI bleed, for example, into small intestine, large intestine carcinomas, right colonic carcinomas, left colonic carcinomas, appendiceal carcinomas, and other bladder carcinoma can present to you with different symptoms. But these patients tend to have a chronic history. The patient presents to you with weight loss or weight gain. At times, the patient loses weight over the period of time. There are symptoms which involve right colon or left colon. Change in stool caliber. Constipation can be a sign of carcinomas, prolonged constipation. Elderly age can be a sign of prolonged carcinoma. Multiple risk factors include diabetics, bedridden, bedbound, patients with prior histories, adhesions can present with carcinomas and further and have a history of these similar complaints in the past as well. Often asymptomatic. Carcinoma, as I mentioned before, takes time to develop. It is a series of pathophysiology that occurs while having a carcinoma. It usually is asymptomatic. Palpable mass. On an abdominal examination, you tend to have an abdominal mass, a globular mass, a small mass, or a big mass that occupies a large portion of abdomen. These are very, very important, helpful examination points that you need to understand and you need to remember while making or doing an examination of patients. Or do you suspect a carcinoma? So weight loss, change in stone caliber, patients are often asymptomatic, any palpable masses, elderly age, think of carcinoma. Wasted, patient is emaciated, there is the decreased hydration status, the patient is poorly tolerated, the patient looks toxic with advanced stage carcinoma. So what to do in these patients? Colonoscopy. Colonoscopy in lower GI bleed is the treatment of choice. But the problem with colonoscopy, especially when the patients with acute lower GI bleed, is you have to prepare the bowel. You have to clear the bowel. So the endoscopist uses a solution which is used to clear the bowel and prepare it for colonoscopy. There were a few limitations with colonoscopy and endoscopy. With endoscopy, upper GI endoscopy, collection of blood inside the stomach or any cavity could resist or limit the accessibility or visuality of the patient, of the endoscopist, to the bleeding point. And same goes in the lower GI tract when there is stool present, which can limit the visual attention to the bleeding point with which stool is impacted. So have to prepare a bowel, and you have to clear the blood collected in the cavities of the upper GI bleed, and that is why nasogastric tube is used just to aspirate as much as it can, so the colonoscopist or endoscopist could see what the bleeding point and help to close it or embolize it. Biopsy is definitive in these patients with a suspected carcinoma. If you suspect or if you find an abdominal mass, go for a biopsy and wait for the results. These are the biopsy is always definitive in patients with suspected carcinomas. Surgical evaluation for these abdominal mass and suspected carcinomas. And again, before going into surgical evaluation, you have to make sure the patient is stable. How do you make sure the patient is stable? With no active bleed, with pertinent or a widely hemodynamic stability, and the normal GCS levels. So some other differential diagnoses in lower GI bleed: diverticulosis, painless bleeding per rectum, bright red blood per rectum, hemodynamically unstable. They can painless bleeding, which is unnoticed at times, especially in elderly males or elderly females, but it can later on present with hemodynamic instability. Early colonoscopy, angiography, and tag cell study is very, very important in these patients. Hemorrhoids, there are two types of hemorrhoids: bleeding internal hemorrhoids and external hemorrhoids. So bleeding hemorrhoids is also a common cause of perectal bleed, and it is again fresh red perectal bleed, external painful bleeding, and internal painless bleeding. Seen on external examination or proctoscope or anoscopy, both are the same things. You put a proctoscope, you look for internal hemorrhoids and look for the degree of hemorrhoids, if it's first degree, second degree, or third degree hemorrhoids. If the patient is non-thrombosed, if the hemorrhoids are non-thrombosed or not actively bleeding, and the patient is widely stable, this patient could be sent home and for surgical evaluation in outpatient clinics. Infectious diarrhea, especially patients with inflammatory bowel disease, ulcerative colitis to be precise, can present with dysentery and bleeding per rectum. Painful diarrhea with fever, blood or pus in the stool, heme positive stool or diarrhea. Perform stool cultures, gram staining, fecal WBC count or stool routine examination. Antibiotics, if indicated, with the fever and ulcer patients with fever or bleeding and the pus, or there is increased tendency of bleeding with the fever, think of any gastrointestinal infection which is causing the patient to bleed, and this patient needs appropriate antibiotics. Inflammatory bowel disease, abdominal pain, rectal bleeding, weight loss, and fever. Inflammatory bowel disease includes two types: ulcerative colitis and Crohn's disease. Ulcerative colitis at times is associated with dysentery, so they present with abdominal pain, rectal bleeding, weight loss, and fever. Fresh PR bleed, they can present with melena and heme positive stool. There might be abdominal tenderness because of any inflammatory process underlying. So you look for a complete blood count, colonoscopy, or may require a surgical consult in these patients. Ischemic colitis patients can present with out of the proportion pain, out of the proportion epigastric pain. Patient might have a risk factor, for example, atherosclerosis before, atrial fibrillation. So patient present to you out of the proportion pain and the abdomen, and that's not relieved with even analgesics and NSAIDs and everything. You have to go for higher dose of opioids. Think of mesenteric ischemia. Mesenteric ischemia can present with heme occult blood and bleeding per rectum. So if a patient comes with clotted blood and with pain out of the proportion, elderly with multiple risk factors, think of ischemic colitis. Severe abdominal pain and rectal bleeding, diffuse abdominal pain or peritonitis, urgent surgical evaluation, angiographic intervention, or CT angiography is highly recommended in these patients to look for any atherosclerosis changes or mesenteric ischemia in the abdominal aorta. Meckel's diverticulum, painless melena, hematochezia and abdominal pain, chronic anemia or acute blood loss, they can present in both conditions. So Meckel's diverticulum could be diagnosed with angiography or tagged red cell scanning and can be with surgical excision. Moving on to some general treatment principles. with upper GI bleed, it is recommended, some drugs are recommended in patients with upper GI bleed. Antacids are not widely used now because they cannot have any effect on mortality or morbidity in the patients with upper GI bleed. Antibiotics, especially in the patients with liver cirrhosis and suspected spontaneous bacterial peritonitis in the patients with advanced liver diseases, they need empirical antibiotics. Moving on to some histamine blockers and proton pump inhibitors. What happened? These are widely used and highly recommended in patients with upper GI bleed. They contribute to decrease the secretions of gastric mucosa, which further in the future it does not have an active role in stopping the bleeding at that very moment, but with the decrease in acid secretion, it helps to prevent or further bleeding in the future from the gastric mucosa. So it is said in some literature, 80 milligram IV stat is given in patients with upper GI bleed of omeprazole and proton pump inhibitors. And at times, it could be given in IV infusions. Moving on to some other drugs, somatostatin and octreotide. These are vasoactive peptides that decrease the blood supply to esophagus and splenic blood, which help to reduce excessive bleeding from the gastric ulcer or bleeding point in the upper GI bleed. These are widely used at times, but proton pump inhibitors and other maneuvers endoscopy is also is gold standard in patients with upper GI bleed. Vasopressin locally injected or systemic vasopressin, which help to vasoconstrict the vessels, help to decrease the blood flow to the ulcers due to vasoconstriction. But the caution should be taken in the patients where patients could have an organ damage with vasopressin. So endoscopy is widely used, as I mentioned before, is widely used as therapeutic and diagnostic in patients with upper GI bleed. When it's done within 12 to 24 hours of the patient with upper GI bleed, it helps you to identify the bleeding point, the bleeding site, and help you cure the patient with upper GI bleed. It helps to, it can be done with sclerotherapy, it can be done with embolization, or locally injected epinephrine or vasopressors. It is widely used. It's 75 to 85% of the cases patients tend to heal or to recover after endoscopy who are present with upper GI bleed. But the serious limitations are when a patient with excessive blood, which is collected inside the cavities of the gastrointestinal tract, the endoscopist could not tend to locate the bleeding point, and at that point, the nasogastric suction is beneficial to empty the stomach and clear the passage for the patient to visualize the bleeding point. At times, if endoscopy is not beneficial, one can go for other examination of that's gastroesophageal tamponade, and that is direct pressure, putting a pressure on the vessels of GI tract to stop the bleeding. It is temporarily helpful, but can lead to perforation, ulcers, and rupture of the structures. Interventional radiology should be taken on board for active bleeding, and with the failure of endoscopy, they tend to identify the bleeding vessel where the dye injected via CT angiography. They tend to locate the bleeding point, and with intervention, they do with the radiologist embolize or sclerotherapy of that site which is bleeding. Surgery, if all the modalities are failed, the patient should be taken for surgical evaluation and should be going through a surgery to locate the bleeding point and to stop it. So in general, upper GI bleeding, the initial treatment should be starting with omeprazole, that's 80 milligram IV stat. Following that would be an urgent consult from an endoscopist and interventional radiologist for further management. Moving on to lower GI bleeding treatment plans. The first thing to do is colonoscopy. How would a patient present to you with lower GI bleed? Let's recall. It's hematochezia, fresh PR bleed, and at times melena. Colonoscopy is direct visualization of the lower gastrointestinal tract. So it is directly therapeutic and high yield and extremely important and useful in patients with lower GI bleed. It is considered the intervention of choice. But the serious limitation in while working in emergency department is at times the gut, which is to be prepared for endoscopy, is not prepared in emergency department. So what they do is they perform a nasogastric tube intubation and administration of 2 liters of polyethylene glycol, which lead to volume loss by osmotic diuresis. So one has to be sure while doing this process the patient is hemodynamically stable. Moving on to sigmoidoscopy. Sigmoidoscopy is also used in patients with lower GI bleed, but comparatively to the colonoscopy, sigmoidoscopy is not widely used or widely recommended in patients with lower GI bleed, but could be performed if colonoscopy is not helpful. Angiography, again, if sigmoidoscopy is not helpful in these patients, or there is some bleeding point could not be identified because of operator failure or some other problems, which the angiography should be done to rule out any bleeding point, which tend to identify the bleeding from 0.5 to 1 ml per hour. TAG red cell imaging. It's also technetium-99 scan dye is used, which can detect blood effusion of around 0.1 ml per hour as well. Vasopressin, again, systemic vasopressin could help to vasoconstrict the vessels, but again, with end organ, it can help. It can exaggerate, or with watershed areas, they can tend to have a ischemic or decreased blood supply to those organs because of vasopressin, which tend to lead to end organ damage. Surgery as last resort for anything which is not been identified with all the maneuvers or all the radiological studies or treatment options that we studied before in this slide. Moving on to indications of transfusion. Transfusion tend to be one there is ongoing blood loss, hemoglobin is less than 8, and much more, which explained in this slide. Hypotension, persistent hypertension despite fluid resuscitation, transfusion is required because blood is to be replaced with blood. Evidence of volume depletion, how do you check it? Decreased hypotension, tachycardic, altered mental status, decreased urinary output. These are the signs of the volume depletion. Sware distress, patient is also sensorium, patient is not vitally stable, patient GCS is not 15 by 15, so the patient is in hemorrhagic shock. These patient needs transfusion. Cardiac ischemia, patients who cannot be given IV fluids because of previous ischemic heart disease, they should be given a blood transfusion to maintain the hematocrit more than 30, so the organs have been perfused and heart activity has been perfused with adequate blood supply. Massive blood loss. Massive blood loss is to be documented with the history of the patient. At times it is difficult to identify the amount of blood that being lost, but with the aspiration of nasogastric tubing, or a patient who could roughly estimate the loss of blood should be given, when you suspect a severe blood loss, should be given a blood transfusion. If falling hemoglobin values, hemoglobin less than 8 should be transfused with packed red blood cells. Ongoing blood losses, despite everything, despite hemoglobin more than 8, but if there is ongoing blood loss, you have to transfuse the patient with PRBC packed red blood cells. Indications for plasma, vitamin K and platelets, gastrointestinal bleed, elevated prothrombin time, PT time indicates plasma. Liver diseases, vitamin K is useful in these patients. Patients with chronic liver disease tend to have decreased platelets or thrombocytopenia. They need platelets transfusion, vitamin K deficiency. Patients with warfarin therapy and increased INR ratio, where they need fresh frozen plasma to be transfused, because with warfarin toxicity or warfarin increased INR, patients tend to have increased tendency of bleeding. Other coagulopathy the patient is having before in the past, these patient needs plasma. This patient needs vitamin K and platelet. It is said in some literature, patients with ongoing bleed should be given 1:1:1. That's 1 of PRBC, 1 of plasma, and 1 of platelets. So moving on to some special patients. We'll talk about bleeding in pediatric population. The most common cause of upper GI bleed in pediatric population is esophagitis, followed by gastritis, ulcers, variceal bleed, or Mallory-Weiss syndrome, Mallory-Weiss tears. The most common cause of lower GI bleed in pediatric population is anal fissure, infectious colitis, and inflammatory bowel disease, polyps, or intussusception. At times, formula intolerance could produce lower GI bleed. Intussusception should be considered early in pediatric population with colicky pain, heme-positive blood or hematochezia, heme-positive stool, hematochezia, or current jelly stool. Intussusception should be suspected in this pediatric population. The management of gastrointestinal bleed is similar to the in pediatric population is similar to the management of GI bleed in adults. Most of the time, the pediatric population is not so severely distressed, or these patients could be or tend to be managed in outpatient clinic. Elderly, on the other hand, these can present with various kind of symptoms, which includes altered mental status, decreased oral intake, and at times their dementia. The patients are of the known case of dementia, but they tend to not to recall the history or the time duration of this bleeding. With advanced age, where there is increased chances of carcinoma, this patient often present with asymptomatic or painless hematochezia or melena. So they cannot really appreciate the significance of the change in bowel habits or colored stool. So the threshold for CT scan or any further aggressive treatment in elderly patient is very low. So if you suspect an elderly patient, the patient should be investigated thoroughly, and the threshold should be low in patients with advanced age. Moving on to immunocompromised, patients who are immunocompromised with steroid therapy tend to have increased chances of ulcers, gastric ulcers, and with immunocompromised patients, they tend to have a recurrent infection in patients who are immunocompromised. So these patients need extra attention and should be given high value in patients because of tendency to rebleed because of persistent immunocompromised status inside. So moving on to disposition of the patients with GI bleed. I tend to classify into 3 parts. The patient who needs a consultant advice or admission, the patients who need just an emergency observation, or patient who could be sent home and are safely sent home. The patients who need urgent consult from a specialty, for example, endoscopist or gastroenterologist or surgical consult or interventional radiologist, are those patients who are actively bleeding. There's falling trend of blood levels despite fluid resuscitation. The patients who are in hemorrhagic shock, decreased hemoglobin levels, patients with aortovenous fistula, patients with gastric or esophagitis, bleeding gastroesophagitis, patient with Mallory-Weiss syndrome, Mallory-Weiss tears, patients with upper GI bleed, which needs urgent or 24 hours evaluation and endoscopy within 24 hours, should be consulted with the endoscopist and the gastroenterologist or interventional radiologist in emergency department for further management. And these patients needs admission. This patient should be admitted and should be given immense importance and should be admitted on the services of intensive care unit. Moving on to the other classification, that's who the patient should be observed in emergency. Patients who are not actively bleeding, patients who are vitally stable, patients with serial hemoglobins within normal range, patients who are alert and have no signs of hemorrhagic shock could be observed and should be monitored, but should be advised a close follow-up with the gastroenterologist and general surgeon. Next, the patient who could be sent home. Patient who are not actively bleeding, hemoglobin level within the normal ranges, patient who's vitally stable, there are no chances of recurrent bleed, all the risk factors have been excluded, patient is safe to go home, but these patients should be given a close follow-up to the gastroenterologist in the outpatient department for further management. So in this lecture, it was all about some diseases of which present with gastrointestinal bleed, especially upper GI bleed and lower GI bleed. What are the various things to look for in the patients with upper GI bleed? What are the diseases that causes upper GI bleed? What things to be done in upper GI bleed? Who should be given 24 hours endoscopic service? Who should be sent home? Some diseases in lower GI bleed. What are the diagnostic studies or treatment plans that we can offer? We have for a patient with upper GI bleed, which includes chemical pharmacological treatment, which involves interventional treatment, endoscopy, tamponade, interventional radiology. Then we have for lower GI bleed, that's colonoscopy. That's vasopressor activity, that's pharmacological therapy in patients with lower GI bleed. Then we talked about the indications of transfusion in patients with active GI bleed. Then we talked about some special patients, for example, immunocompromised when steroid therapy, they tend to have increased chances of gastric ulcers. Elderly patients who have a low threshold for disease, patients, a pediatric population, what are the common cause of upper GI bleed in a pediatric population? What are the common cause of lower GI bleed in pediatric population? And at the end was about who should be admitted, who should be advised to see the consultant, who should be observed in the emergency department, and next, who should be sent home safely with close follow-up. That's all for now. Thanks for watching sqadia.com.